Okay, well, thank you, everyone. Thank you for attending today's lecture dealing with radiotherapy and the advantages of short course radiation therapy in terms of maximizing the safety and accessibility for underserved patients. My name's Anthony Dragan. I'm the professor and chair of the Radiation Oncology Department at MD Anderson Cooper in Camden, New Jersey. And I appreciate all of you being here today. I also appreciate the invitation from Dr. B to participate in this. It's a real honor for me. So today, with our learning objectives, we're going to go through an overview of access to care issues that require radiation therapy to have some novel solutions. We're going to focus today on whole breast radiation therapy to do an apples to apples comparison. So we really won't be focusing a lot on accelerated partial breast irradiation, brachytherapy, intraoperative radiation therapy. Those things are subject to another talk. Really, the advances here today are pragmatic advances in whole breast radiation therapy, which are widely applicable. And then we're going to review the background, the rationale for what's called extreme hypofractionated radiation therapy. These are radiation treatments that are over 5 gray per fraction. So I'll define that as we go through the talk. I don't have any disclosures. And so the question is, why are we here? Well, a lot of people talk about NSABP B06, which was the largest randomized trial in the United States to look at mastectomy versus lumpectomy and radiation. And they used a fractionation scheme for radiation therapy that was 50 gray and 25 fractions with or plus or minus a boost. And that was done at 2 gray per day. So 2 gray is the dose of radiation per day that was given, and that was really determined to be what's called conventional fractionation. And this established essentially what everybody talks about as the 5 to 7 weeks of daily radiation. Just for context, this was considered novel technology in 1976. So we've come a long way in a lot of ways in our society in technology, and radiation is no different. So my background and interests, I kind of came up in researching breast brachytherapy and partial breast irradiation all the way back since 2002. I observed how partial breast irradiation improved access to breast cancer care because it was accelerated, it was shortened from that 6-week course of radiation in my early experiences in South Carolina and Georgia. And then I went to the University of Louisville in Kentucky, where I dealt with a lot of surgical oncologists there that were not exactly enthusiastic with partial breast irradiation. The state of the evidence at that point in time, about 2008, really wasn't great. But at the same time, in Kentucky, they have the most underserved population with some of the worst cancer outcomes in the United States. Just to give you a little bit of background, when we looked at and researched the management of early stage breast cancer over about a 10-year period, which was really considered the modern era of breast cancer treatment at that time, we found a couple of unsettling details. Number one is that Kentucky had a very low rate of lumpectomy for this group of people, that the lumpectomy rate or breast conservation rate was about 54%. And this was lower if you lived in rural counties or if you were elderly. And then the radiation rate, meaning that once you got breast conservation surgery, how likely were you to be able to have access to radiation? That was really disappointing. That was only 2/3, where all these patients at that time, the state of the evidence said all these patients should have radiation after lumpectomy. And that was lower for rural patients, elderly patients, and the African American community. And so if we look at what the standard of care was, which is the red portion of this pie graph, breast conservation and radiation therapy, only about 1/3 of patients, a little over 1/3 of patients were being treated that way over this 10-year period of time. About 18% of them were receiving breast conservation surgery alone, which was not the standard of care without radiation, and about 46 were having mastectomy. So and this is significant, especially if you have breast conservation surgery without radiation. There were a number of studies that were published at the time, large studies in SEER Medicare databases. There were audits of National Cancer Institute centers. There were Medicaid databases. There were databases from other Western countries like Australia that showed that you actually had a higher risk of death if you didn't get radiation after breast-conserving surgery. Now, we don't believe that that's all related to the radiation, but it's a marker. The radiation serves as a good marker for quality of care, and we see that the disparities exist among people on Social Security disability, people, African Americans, rural patients, patients of low socioeconomic status, patients with comorbidities, rural patients in Australia. And in Kentucky, we found the same thing, the bottom line here. And ours was the second largest study of its kind at that time and the most modern. And we found that patients did have poorer outcomes if they were older, if they lived in rural counties, if they were African American or uninsured. So the idea was there was this need for a novel, short course, whole breast radiation therapy program. And in 2008, the idea of what was called hypofractionation, or short course radiation therapy, as a lot of people know it today, sort of daily radiation therapy from 6 weeks down to about 3 weeks. Even that in 2008 was considered somewhat fringy. These are radiation fractions, just dialing up the daily radiation dose from 2 gray per day up to maybe 2.5, 2 3/4 of a gray per day, less than 3 gray per day. This, of course, had been done in Great Britain, but the Canadian data really wasn't published until in the New England Journal of Medicine until 2010. But this was the state of the data down here. There was that exists now. We have the Canadian trial, the Royal Marsden trial in the UK, and the START A and B trials in the UK. This is all what we would call modest hypofractionation. So still daily treatment every day, but instead of 6 weeks or 7 weeks of treatment, we're pushing it down to 3 weeks. And a lot of you have seen this. This has become the standard of care over time since that time. But in 2008, this was not really considered in the United States a widely used option. And this was good, but still daily shorter courses of radiation in a state that I was practicing in Kentucky really wasn't enough. And to do a trial of something like that was somewhat pointless because we had these emerging trials that were being done in the UK and Canada. So these emerging shorter courses of radiation therapy were good, but we didn't have the ability to house patients. So a daily, slightly shorter course of radiation therapy was really not considered enough to impact some of these trends. So what we wanted to do was to do something more dramatic, and my institution had support for that at that time. At that point in time, there was some emerging data in Europe of pushing the limits of hypofractionation, and this involved once or twice weekly large fractions of whole breast radiation therapy. This has come to be known in some circles as extreme hypofractionation, things that are over 3 gray per fraction, really over 5 gray per fraction. And the first study that looked at this was published in 2006 in France, and it looked at definitive therapy. This is sort of a proof of principle idea in a toxicity trial where they looked at patients who were elderly who were not able to have surgery but had a known diagnosis of early stage breast cancer, and they were treated with 6.5 gray for 5 fractions to the breast once weekly, and then they had an additional boost of 1, 2, or 3 fractions to the tumor itself for an additional 6.5 gray per fraction. And they actually showed a very good 5-year progression-free survival and with very low levels of late side effects. Teeing off of this, the same group in France looked at an adjuvant study where the patients underwent lumpectomy and then had whole breast radiation therapy, 6.5 gray for 5 fractions once weekly, and they showed very good progression-free survival, comparable to standard fractionation, and nice rates of toxicity. But when we look at the equivalent doses in terms of this fractionation scheme, if we use the alpha-beta equation in radiation oncology to make it equivalent to standard fractionation, what we find is that this is actually biologically a much higher dose of whole breast radiation than 50 gray and 25 fractions, which was the standard. It probably equates to about 62 gray and 31 fractions. And so the UK did a pilot study, and this was published in 2008, and they looked at 30 patients who were over the age of 50. Again, and now we've moved into adjuvant treatment now after a lumpectomy. Very homogeneous population of early stage invasive node negative breast cancer patients without chemotherapy, and they did 30 gray and 5 fractions, so 6 gray per fraction 5 times over 15 days, so twice a week. And they found that there were very low levels of acute toxicity, and cosmetic outcome at 2 years was comparable to other studies. And obviously it wasn't powered for progression-free survival, but they had very good results. And this led to the first randomized study of extreme hypofractionation, what's called the UK FAST trial. And this was opened in 2004 and ran through 2007 with this very same population, over 50, so postmenopausal, early stage invasive cancer patients, node negative, and almost 1,000 patients were included in this study. And they were randomized to one of 3 arms. Number 1 was the standard fractionation at 50 gray and 25 fractions, that's that NSABP B06 trial fractionation scheme, conventional fractionation, 30 gray and 5 fractions, 6 gray per fraction, and then 28.5 gray in 5 fractions, so dose de-escalation to 5.7 gray per day. So you had 2 arms, so over 600 patients of once weekly extreme hypofractionated treatment. And what this slide shows, it's very busy, but I'll just summarize it, that these patients all did very well. Everybody did pretty much equivalent. And there were very few local or regional relapses. Distant recurrence obviously is not impacted by radiation outside of a local regional relapse, and the toxicity was comparable. There seemed to be better cosmetic outcome in the 28.5 gray arm compared to the 30. So that's what we knew was going on at that time. That wasn't published in 2011. So if we go back to 2008, when we were looking at this in Louisville, we identified this as a pragmatic whole breast radiation regimen. You were doing this 1 time per week for 5 treatments, and so it could definitely improve access while avoiding some of the controversies that surrounded partial breast irradiation at the time. And we were going to expand on some of that prior experience and use the fractionation schemes from the UK FAST trial, but also be more inclusive. So instead of just having postmenopausal patients, we wanted to have patients who were premenopausal and postmenopausal, patients with early stage, but also up to 3 positive lymph nodes. This was the standard arm of the largest national trial at that time, which was the NSABP B39 trial. And we looked at 2 regimens. We started with the 30 gray and 5 fractions because that was considered the standard arm of the FAST trial. And then when the FAST trial was published and it showed better cosmetic outcome in the 28.5, we allowed that. And so for a single institution, we accrued over 170 patients, and we published our results. And we had no restrictions on breast size or the use of cytotoxic chemotherapy, which was considered somewhat controversial for this group at that time. And we looked at a couple of these things. So one of the impressive things that we found at that time is that this was a trial that really appealed to our population. For an example, we had about 20%, over 20% African American enrollment. And just for context, the NSABP was reporting that their African American enrollment was less than 5%. at that time. So this was something that we found was really something that was a really important objective for us. We had almost a third of patients were considered large-breasted. We had about 16%, about 10% were node positive. And then we had the majority were intermediate or high grade. We had almost a quarter were ER negative. So this was not like a highly selected group of biologically favorable low-risk patients. And so what we see here is that also about over a quarter had chemotherapy. We did give a boost in almost a quarter of patients as well. And what we found is that after a median follow-up approaching 4 years, we had an in-breast tumor recurrence rate of just 1.2%. Both of these patients happened to be triple negative patients and recurred very, very early. They were both, though, postmenopausal, and one of them was very elderly. As far as cosmetic outcome, we had very comparable cosmetic outcomes to other clinical trials, good to excellent in over 80%. These are some examples of baseline 1 year and then 3-year cosmetic outcomes in our first 4 patients that were treated. And this is very comparable when we look at those French trials. There was another non-randomized retrospective trial from Italy that was published in this intervening time, the pilot study, the FAST study. And if we look at this, the cosmetic outcome in our study was very comparable to all of these other trials. And this is the sort of change in photographic appearance of the breast, which is not just a patient-reported or physician-reported, but an objective measure that was also very comparable to what was seen in the FAST trial. In ASTRO, the American Society of Radiation Oncology meeting in 2018, this was presented, and then this was published just about a month ago in the Journal of Clinical Oncology. This was the 10-year update of the FAST trial. So what I showed you before was their 5-year numbers, and these numbers continue to hold up over time. So when we look at skin reactions from the UK FAST trial comparing conventional fractionation 50 gray and 25 to 30 or 28 gray in one weekly fraction of 5.7 or 6 gray, we find very good and even lower acute skin reactions with the shorter course. Here's a change in photographic assessment over time, and what you can see is that 28.5 gray and 50 gray seem to be equivalent in terms of cosmetic outcome over time. The 30 gray arm seems to be a little bit too high of a biological dose in terms of late effects and change in breast appearance. And so these are the numbers for local regional recurrence and distant relapse. And you can see there's no differences in distant relapse as we would expect. No breast cancer specific survival differences, and no local recurrences. And this is with 10 years median follow-up. So with this, the UK, and this is a little bit Greek to a lot of you who are not in the radiation oncology business, but the alpha beta ratio is what we use from a radiobiologic standpoint to look at equivalent doses with different fractionation schemes. And when we look deeper into these trials and we look at the radiobiology, what we're looking at is that 30 gray in 5 fractions is probably equivalent to about 57 gray. And again, the number we're looking at is 50. For biologic equivalence, and 28.5 gray is likely equivalent to about 52. So still a little bit high here in terms of biological equivalence. And so in the UK, they calculated that the right dose then would be somewhere around 27.7. So again, we're dose de-escalating with these larger doses per fraction. We're de-escalating the total dose. And so this leads to, in the United Kingdom, a very large trial called the Fast Forward trial. And now we're looking at a much larger group of people. We're talking about over 4,000 patients accrued in a very short period of time from 2011 to 2013. Then they opened it up to an additional 700 patients who they treated with regional nodal irradiation. So now no longer just whole breast radiation, but patients treated to their regional lymph nodes. And they included a much larger cadre of people here, over 18, up to T3, up to N2. They allowed a boost. They even did this in the post-mastectomy setting. And their control group now became the standard daily hypofractionated patients, the 3-week course of radiation, which now had replaced conventional fractionation for patients in the United Kingdom. So that became their standard arm, and then their test groups were 27 gray and 5 fractions or 26 gray and 5 fractions. So 2 test groups, 2 experimental groups, very similar to the FAST trial. And then they did all of the robust physician, patient, and photographic assessments of toxicity. And this is what they presented at ASTRO in 2018, and this was published in The Lancet in just April of 2020. And what this shows is that acute toxicity is much better. It peaks at about the same level or even a little bit lower than acute toxicity with the more conventional treatment and resolves a lot sooner. And this goes for grade 1, 2, and 3 toxicity. The rate of grade 3 acute toxicity is very, very low in the shorter course of radiation. So it's not only a shorter course, not only more convenient, not only more access to care, you're actually getting lower rates of acute toxicity. This is a busy slide, but what it basically shows is the change in appearance of the breast with cosmetic outcome in the patients who had at least 2 years follow-up. And so what you're looking at is the thin purple bar here is what you want to look at with the standard arm to the 2 experimental arms going left to right. And what you're seeing is that this, whether you're talking about overall change in breast appearance, the size of the breast or breast atrophy, the appearance of the skin, or the firmness to the touch, you're seeing equivalence in all of these metrics. Here's some of the patient assessments in terms of their overall breast pain or swelling. And again, you're seeing equivalence in all of these metrics. This is physician-assessed late toxicity or change in appearance over a period of time. And what we found is that the 26 gray dose is equivalent to the 40 gray dose, and it's a little bit worse in the 27 gray. So again, they keep dialing the dose down and finding that the outcomes are equivalent and the toxicity is better as you start to get into an accurate assessment of biologic equivalence to some of these other fractionation schemes. So the fast forward conclusions are that basically the adverse events were low in all the groups. That's the 27 gray is consistent with 50 gray and 25 fractions. And this is 27 gray and 5 fractions. 26 gray and 5 fractions is similar to 40 gray and 15 fractions. And this is the first follow-up at 5 years. They're still waiting to publish their subgroup analysis for lymphatic irradiation. And so if we look at the strategy overall, and I would be looking at this top line here. We start out with whole breast radiation therapy, which was 50 gray and 25 fractions over 5 weeks. They go with the Royal Marsden study, which was the START pilot, START A and B in the UK, and then fast forward. And that really what we're looking at is a 5 fraction treatment, whether you do it the way that FAST did it, which was 1 fraction per week for 5 weeks, or Fast Forward just did it 5 fractions in a row for 1 week. And then at the same time, and this is another talk for another time, they're looking at comparing these same whole breast radiation regimens to partial breast radiation. So in conclusion, The extreme hypofractionation, that these are fractions of radiation that are over 5 gray, seem to be a promising and pragmatic alternative to daily radiation. The potential of this is pretty significant because we can improve cost efficacy of treatment, access, and because these didn't involve any kind of special equipment, special setup, any special procedures, the only difference between this and conventional radiation is the amount of radiation that you're giving per day. It has an extremely wide applicability. And we have, with the 10-year publication of the FAST trial, I think this is becoming a more mainstream option outside of the United Kingdom. And I believe it's a really important part of an all of the above approach to alternative breast therapies, both daily hypofractionation, partial breast irradiation. Some people have talked about intraoperative radiation. There are some studies going on about stereotactic body radiation therapy, or SBRT. But this seems to be the modality that has the widest applicability and ability to change practice on a broad scale in Western countries. I found that this option was incredibly useful during the COVID pandemic, because what were we trying to do from the very beginning? Limit the number of times people had to come into the hospital, limit the number of times they had to come out of their home, limit the number of people that they would interact with. And I actually had a lot of people reach out to me during this period of time, because our study at that time was really the only one from a United States institution asking questions about whether they felt that certain patients were appropriate for this type of treatment. And there was actually a survey that went out asking people if they would be more or less likely to offer something like this in the setting of the pandemic, and the results were very positive. So it represented a modality where it was easy for physicians to shift gears and change into this, because it didn't, like I said, involve any additional equipment or technology. It's using your existing technology, just upping your dose per treatment, and it allows for the limitation of visits and social distancing. My advice to people in my own field, and especially thought leaders in breast cancer radiation, is that really the United States got somewhat left behind and undercut by some of these newer strategies that were being investigated in the United Kingdom and Canada. And it really had to do with some of the preconceived biases against lower number of treatments. Some of the way that we're structurally set up in the United States as far as radiation therapy, with our fee-for-service reimbursement structure, has held us back, and that clearly has undermined the ability for investigators in the United States to access these types of treatments for their patients. Now, that's changing with alternative payment models coming into the marketplace, and in some institutions seeing some of the writing on the wall of where the field is going and the direction it's going. I think that that's changing, but it did, I would say, over the decade of the early 2000s to 2010, really did hold back a lot of the innovation in the United States. One of the things that I think was extremely important to take out of our experience with this type of trial is that I had been to a lot of conferences where there was discussion about underrepresentation of minority and underserved populations in clinical trials specifically. And one of the learning points that we found out in this study is that if you identify a need in your community and you identify a disparity in your population, whether it be access to care or outcomes, it's not enough to just identify that that disparity exists. This trial, these modalities, in my experience, were an endeavor to remedy that disparity. And so this type of treatment was designed and was picked for a clinical trial with underserved populations in mind. And when you do that, what ends up happening is, just by virtue that you're offering people something that is meaningful to them, you increase your enrollment of some of those patients in who we've seen disparities in the past. And I think that, in addition to some of the things that we've learned about the efficacy in the setting of a pandemic, but as we've learned and identified and become more aware of some of the disparities that exist in our healthcare system, and become more aware overall over the last months about the exacerbation of some of these things when society is under stress, I think we should all be aware when we're designing clinical trials going forward into the future of the populations that we serve. So with that, I would like to thank everybody for their participation in this conference. I'd like to again thank the selection committee and Dr. B specifically for inviting me to give this talk, and I will look forward to answering all of your questions. Thank you.